Hi, everybody. Good morning. I'm Yen Wui. I am co-chair of the Professional Education Committee for ISTM, and I am very pleased to welcome you to our first webinar for 2022. And I'm very honored to introduce our moderator today, Dr. Christina Angelo. She is an infectious disease physician with expertise in traveler's health and tropical medicine. Dr. Angelo is a medical epidemiologist at the Centers for Disease Control and Prevention in the Division of Global Migration and Quarantine in the Traveler's Health branch. She also practices both travel medicine and infectious diseases at Emory University hospitals and clinics. She is the project officer for GeoSentinel, a global disease surveillance system that reports on travel-related illnesses. Dr. Angelo has a particular interest in infectious disease epidemiology, the clinical practice of tropical medicine, pre-travel vaccination, mass gathering medicine, and outbreak response. Over to you, Christina, and thank you for being with us today.
Thank you, Ian. Appreciate it, and welcome everyone. Just a few announcements before we get started. Please note that today's program is being recorded and all attendee audio and video is muted. Today's presentation will be approximately 90 minutes and includes an opportunity for questions and answers. You can submit your questions at any time through the Q&A panel at the bottom of the screen. And please remember that the chat is not going to be routinely monitored. So please ensure that your questions are placed into the Q&A. In the Q&A session at the end of the webinar, we'll answer as many questions as time will allow, depending on how much time is available. You can turn on closed captioning during the webinar. There's a live caption button at the bottom of the Zoom screen. It's a free service provided by Zoom, so it might not be 100% accurate, so keep that in mind. There's slides for this program that can be accessed in the handouts tab of the program on learning.istm.org. And you'll find the webinar page on your dashboard once you're logged into the ISTM website. So ISTM is pleased to present this online educational webinar, Dengue in the Times of COVID-19, Focus on Travelers. It's actually part of a two-series presentation on dengue webinars. And series 1, the experience in endemic countries, is already available on the ISTM Learning website under webinars. This webinar is brought to you by Takeda Pharmaceuticals, ISTM, and the ISTM Professional Education Committee. We have 3 distinguished speakers for this webinar, each of which will give approximately a 20-minute talk. The first presenter will be David Hamer, who will be presenting on the epidemiology and clinical manifestations of dengue in travelers. Dr. Hamer is a professor of global health and medicine at the Boston University's School of Public Health and Medicine, a faculty member in the National Emerging Infectious Diseases Laboratory, and an attending physician in infectious diseases and director of the travel clinic at Boston Medical Center. He is an infectious disease specialist and medical epidemiologist with particular interests in emerging diseases, tropical medicine, travel medicine, infection control, and antimicrobial resistance. He's also the surveillance lead for GeoSentinel, which I myself work on, which is a global surveillance network of infectious diseases among international travelers. So thank you, Dr. Hamer, for joining us. Secondly, we have Dr. Stephen Schofield, who will be presenting on the efficacy of personal protective measures. Dr. Schofield works with the Canadian military as a scientific advisor and had a particular interest in assessment and management of travel-associated diseases, especially if it involved things with 6 or 8 legs. This was a past life, and he now sees SARS-CoV-2 everywhere he looks, because it is. He is fortunate to have been allowed to play with people way smarter than him, including 20 years with the Canadian Committee to Advise in Travel and Tropical Medicine, also known as CATMAT. In a past life, he obtained a PhD from Imperial College, where he spent a lot of time catching things with wings before they could bite. He lives in Donrobin, outside of Ottawa, where he sits way down in the household pecking order, which includes way below his 2 family dogs. And lastly, we have Yassim Yashim Tozan, who is going to be presenting on cost of illness in travelers. Dr. Tozan works at the New York School of Public Health in the Global and Environmental Public Health Program. Her research investigates the economic burden of disease and cost effectiveness of public health interventions and programs in low and middle income countries. Her focus is on infectious disease prevention and control, with an emphasis on vector-borne diseases and the dynamics of vector-borne disease emergence and spread as it relates to climate, vector biology, and human mobility for the development of an early warning system. In research projects funded by the Swedish National Research Council, her primary focus is on integrating infectious disease models with health economic models to optimize intervention strategies and inform resource allocation decisions. Now I will turn it over to Dr. Hamer to start the program. Dr. Hamer, the floor is yours.
Thank you very much, Dr. Angela. Let me just pull my slides up. Okay. So I've been asked to cover both the epidemiology, but also the clinical manifestations of dengue in travelers, and it's a fairly large topic. But what I'm going to do is talk about the burden of disease, a little bit about what we know in dengue and returning travelers, clinical manifestations of dengue, including some data from traveling populations. And then I'm going to finish talking a little bit about sort of the changing epidemiology of dengue worldwide, including the impact of global climate change and the impact that is having on the distribution of the mosquito vector. Just a couple conflict of interests. I've served on advisory boards in the last year or 2 years for Takeda, Valneva, and Bavarian Nordic. I'm not going to be speaking about any vaccines today. So this is a picture showing the world's deadliest animals, and I'm not sure you can call a mosquito an animal, but it leads the list in terms of deaths caused per year. And mosquitoes are the primary vector for dengue. Most dengue is transmitted by Aedes aegypti, which prefers to bite humans and are daytime biting mosquitoes. Aedes albopictus has similar daytime biting behaviors, but this is a little more widespread in terms of the host that it likes. It will take humans if they're present, but it will also feed on mammals. But I think most areas where dengue is transmitted, Aedes aegypti is the primary mode of transmission. This is a map from a few years ago that Cameron Simmons from Melbourne put together in a really nice review of dengue in the New England Journal. And this shows areas in dark orange and yellow that have high suitability for dengue. And you can see much of basically sort of the equatorial from the Tropic of Cancer to the Tropic of Capricorn has a risk of dengue. And this may be changing because of a gradual warming of the planet. So it's hard to come up with really precise estimates of the global burden of dengue. These have been modified over the last few years. Current estimates are about 3.6 billion people at risk worldwide for dengue, around 390 to 400 million infections per year. Many of these are asymptomatic, so only about 25% lead to symptomatic infection, and only a subset of those will develop severe dengue. And require hospitalization. There are about an estimated 40,000 deaths. And notably, my apologies, the Global Burden of Disease study that was published fairly recently estimated that there's been a 400% increase between 2000 and 2013. So I'm going to just talk a little bit about clinical manifestations. This is a broad overview from a review in Nature Microbiology a few years ago. And you know, this is really a systemic illness with often, fever, headache, joint pains, maybe even bone pain, hence the nickname breakbone fever. There may be rash, there may be petechiae, and then in more severe cases, more cutaneous bleeding and even internal bleeding. I'm going to talk a little bit more about this, though. So this is a description. So often dengue will start out with a fever associated with headache, vomitings, myalgias, arthralgias. There may be a rash. It may be relatively transient, usually a macular erythematous rash. There may be milder hemorrhagic manifestations, petechiae, and then often enlargement of the liver. Major lab abnormalities include a low platelet count, mild leukopenia, and then elevated transaminases. And this first phase usually lasts around 3 to 7 days. This may be followed by improvement, but then in some cases, people will progress and develop a vascular leak syndrome. And this can lead to major complications, including intravascular volume depletion, a rising hemoglobin. It can lead to shock, and then bleeding may also occur. In some cases, there may be profound thrombocytopenia, and then a number of different central nervous system, cardiac, and ocular complications. With good supportive management, then this will gradually resolve over a period of a few weeks. I think there's less evidence about what happens after that, but we're actually doing a study within GeoSentinel called Chitazima that's looking at the sort of longer, I say medium to longer term symptoms and impact on quality of life that dengue has. So we'll be learning more about that over the next 6 months or so as those analyses continue. And for years, there's a lot of variability in how dengue was diagnosed. The World Health Organization addressed this by putting together a group of experts, and they came up with these guidelines, which are really sort of excellent guidelines for both diagnosis, treatment, prevention, and control. And they also came up with definitions for probable dengue, which is listed on the left, which are really many of the symptoms that and signs that I just described. If it's laboratory confirmed, then it becomes confirmed dengue. There are certain warning signs, so abdominal pain or tenderness, persistent vomiting, edema, mucosal bleeds, change in neurologic status with lethargy. And all these are worrisome if they occur. What is even more worrisome is if this progresses to severe dengue. So in this case, there's severe plasma leakage, there may be bleeding and severe organ impairment. And you can see the list of the descriptions to the left there with very elevated transaminases and impact on the neurologic status and potentially cardiac and other complications. This is a picture going back to Cameron Simmons' review of some of the cutaneous manifestations of dengue. And so you can see in the upper left, there may be an ecchymosis at a venipuncture site, a little more prominent on the right. And sometimes there may be oozing. Down here on the left in C, there's a large ecchymosis. And then this in D is very faint, but it's showing a faint macular rash associated with acute phase of dengue. And there may be more intense manifestations, including a subconjunctival hemorrhage, like in this young man. So I'm going to shift and talk a little bit about dengue and travel. I put this picture of Sri Lanka in, which I visited with Lynn Chen a couple of years ago. Absolutely beautiful place, but Sri Lanka has had problems with dengue over the years. So this is a compilation of a number of different studies. Some of these were reviewed a couple of years ago in a review paper in the Journal of Travel Medicine. And then there's a few others that I've added to this. You can see that first of all, they're different populations. In some cases, there are really primarily tourists traveling from certain countries, the Netherlands, Israel, Australia. The article by Hess et al. Was US military. The last was a study that we did of Boston area travelers. And the incidence rates vary. We found a somewhat higher incident rate per 1,000 person months. And may relate to differences in exposure, destinations, and so forth. So like sort of endemic populations, a substantial proportion of infections are subclinical in travelers, in anywhere from 25 to 64%, based on the number of different studies that have been published. The symptoms are very similar to what people experience in endemic areas, with a large proportion having fever, a fair number having myalgias, headache, Rash is somewhat variable. Leukopenia is quite common, as is thrombocytopenia. And I just want to remind everyone that dengue, there's a lot of clinical overlap with chikungunya and Zika. Now, fortunately, Zika has largely disappeared from many parts of the world where we're seeing it not very commonly in travelers. Chikungunya pops up sporadically and causes focal outbreaks and disappears again. There are other viruses like myrovirus that are less common, and they all have substantial overlap with dengue. So if you're seeing a traveler with these kinds of symptoms, you should really be thinking about potentially all three. And I think the only difference with dengue is that there's a little bit more likelihood to have bleeding with dengue than with Zika or chikungunya. And I'm not going to talk about diagnosis, but just quick 30-second spiel on it. During the acute illness, PCR may be positive because there's a brief period of viremia. So for 4 to 5 days, you may be able to identify dengue 1, 2, 3, or 4 by PCR. The non-structural 1 antigen is present for a little bit longer. So that's often used for diagnosis of acute dengue where available. And after that, it's serology with IgM and IgG. The challenge there is cross-reaction with other flaviviruses, including Zika. So these are there's some data on other populations that are at increased risk. There's some suggestion on older travelers, especially those with more medical comorbidities, sort of like those who are at higher risk for COVID, may be at higher risk for severe disease as well with dengue. There's really not much in the literature on the risk of dengue and bleeding with travelers on anticoagulants, and nor is there a lot on dengue among pregnant travelers. There's definite evidence from dengue endemic areas of adverse sort of maternal and newborn outcomes in women who develop symptomatic dengue. So there's probably a risk for pregnant women who are traveling to dengue endemic areas. And for sickle cell disease, there's some limited data suggesting a higher risk for more severe disease. So next couple of slides are just a tiny bit of data from GeoSentinel. So this is an article that Ellie Schwartz led this analysis a number of years ago. There were a little over 500 returned travelers with probable and confirmed dengue. About nearly 70% had been to Asia, and then about a quarter had been in Latin America and the Caribbean, and then a smaller proportion in Africa, and then the Pacific, South Pacific. There was some seasonality in South Asia. May to December was the greatest period of risk, whereas in the Southern Hemisphere in March in South America, there was a greater risk. And then for the Caribbean, it was similar to South Asia with a period from basically late summer through the end of the year. There's also a larger global analysis that Karin Leder led a few years ago that was published in the Annals of Internal Medicine, which was really an attempt to describe the typical diseases in return travelers, stratified by region, purpose of travel, and then characteristics of demographic characteristics. And this is a large analysis of over 42,000 ill-returned travelers. About a third had been to Asia and about a quarter to sub-Saharan Africa. There were a number of different major syndromes, with gastrointestinal leading the list, but then febrile syndrome not too far behind it. And as we often see with GeoSentinel analyses, only a small proportion had reported pre-travel medical visits. So just a quick look at the data. Sub-Saharan Africa, at least at this point in time, had dengue was not a very common diagnosis. Whereas you can see in Latin America, the Caribbean, and Southeast Asia, this was one of the most common diagnoses relative to other diagnoses. This is looking at purpose of travel, and it really didn't matter what kind of traveler it was. Everybody was at a relatively equal risk for acquiring dengue. There are other data. The CDC, there's an organization called ArboNet, and a couple of years ago, they pooled data from both CDC data and ArboNet data. They had 732 laboratory confirmed cases among US travelers. Notably, a little less than half were hospitalized, and there was one death. And you can see that there's a gradual rise, at least between 2005 and 2008. Whether this is because there's more dengue or better reporting is open for discussion. The same database were used, the ARBANET database, for an analysis that was published just about 2 years ago. And this is important for a couple reasons. One is it shows the different regions, and you can see that South, Central America, Asia, and Caribbean account for many of the cases. Now, you have to remember that this is a U.S. focused analysis, so some of the Latin America and the Caribbean may be closer for U.S. travelers. They may be a little less likely to travel to Asia or Africa. And I think the notable part of this analysis is, and first of all, they had a number of locally acquired cases as well as travel associated. But amongst all of these, the risk of severe dengue in this traveling population was very low. It was less than 1%. And there were a few deaths, so it is definitely possible for a traveler to develop severe dengue and to die, but it's not too common. This is a review that came out just recently, looking at dengue in Italy, and really imported dengue in Italy, although Italy has had one local outbreak last year. And this just shows the sort of trends for the EU, the European Union, as well as Italy. And I think the question is, in 2018, 2019, is there a rise? It's really hard to tell whether there's a progression, but based on the global burden of disease study, there may be an increasing risk worldwide of dengue. And then also very recently, there's a review of over 11,000 travel-related dengue cases reported to the European CDC, European surveillance system. About 70% were required in Asia and 18% Latin America and the Caribbean. And they looked at the rates of infection among travelers based on the number of cases per 100,000 travelers. And I think a couple notable things is, one, in recent years, there's been increasing evidence of dengue being acquired, especially in coastal areas of Africa. And I think you can see some of the dark areas there, and then continued high risk in Southeast Asia and South Asia, but also parts, especially northern South America, Central America, Mexico, and the Caribbean. They also identified 9 autochthonous outbreaks in Europe, 6 in France and 3 in Spain. Notably, the evidence suggests that severe dengue is relatively rare in travelers, and that dengue-related deaths are very rare. Ralph Houts and Eli Schwartz reviewed this. It was in the Journal of Travel Medicine last year. But interestingly, because most dengue cases in travelers are primary, the estimate is that 20% or less are secondary infections, that these cases of severe dengue that are occurring in travelers are probably occurring from primary dengue infections. This is one case I think's worth highlighting. This is, sort of where I'm afraid the world is going because of broader distribution of the vector. But this is a case of somebody who had been to Honduras several months earlier, but had not traveled recently, presented with a febrile syndrome to the emergency room and was thought to have acute cholecystitis. Eventually had a series of complications, had surgery, and ended up dying, and wasn't really until late in the hospital course that they realized this person had dengue. They were able to do a phylogenetic analysis of this, and it basically matched up with strains from Cuba. So the thinking was that somebody from Cuba had been in the Miami area, local mosquitoes that were competent vectors had picked up the dengue and then transmitted it to this local person. So it just reminds us that we need to be thinking about dengue even at home, at least in certain locations. This is sort of a figure that Tony Fauci uses often with his talks, and sort of buried in the midst of all this is dengue. You can see here, but there are a lot of other emerging diseases. What are some of the reasons why dengue has been rising? Well, one is physical environment. There are the vector Aedes aegypti and Aedes albopictus are able to breed in small amounts of standing water. So household water stores, manholes, used tires. Climate change and changes in weather patterns may lead to increased rainfall or increased standing water. And then there's been a lot of movement through international and domestic travel, as well as population migrations in certain parts of the world. And then if there's really no surveillance in place, if people aren't thinking about it or don't have the tools to diagnose it, then outbreaks may be missed. Yeah, this is a figure from an article by Dwayne Glubler a few years ago, showing the impact of the global malaria campaign, where they're trying to wipe out anopheles, and they actually led to a substantial reduction in the distribution of Aedes aegypti, but it came roaring back in the subsequent decades. And this is a figure that Desiree LeBeau at Stanford gave me permission to use. And this just shows the 5-year average of temperature change compared with the late 1800s. And you can see the progressive warming pattern of the globe. And the last couple slides here are really looking at some more recent data. So this is an analysis that was published in the Journal of Travel Medicine recently, looking at dengue and the evolving pattern over 30 years, and with the dark red being areas with a higher age standardized incident rate in 2019. And again, Asia, South Asia, Southeast Asia, but increasingly Africa is being identified, especially coastal West Africa, but also parts of coastal East Africa. This shows rise in both high income areas and low income areas. So it's fairly uniformly distributed in many parts of the world, but especially in low middle income countries. And finally, the last couple pictures are maps. These are analyses that Moritz Kramer and others at Oxford have done, looking at the changing sort of estimated distribution of Aedes albopictus and Aedes aegypti. Aedes aegypti is figure B, and you can see that it's become more widespread. So these are areas, and then C is, I think, Aedes albopictus. This has become much more widespread in Europe. So there's a lot more areas in Western Europe and parts of the United States that have competent vectors to transmit dengue. And this is their analysis looking ahead to 2050, suggesting that there may be a much greater distribution of these vectors in much of the United States, especially the south central, southeast, but working its way up the Atlantic seaboard. This is looking ahead to Europe and anticipated that many more parts, especially in the Mediterranean basin countries, may be at risk for diseases carried by Aedes albopictus. And this is more of the same. I think I'll pass on this. And just to say, this is a picture I got when Zika, actually around the time that the US CDC did something very unusual. They declared Miami or a travel advisory for Miami. And this is one of the first times within the United States, within continental United States, that a travel advisory had been put forth. And I'm worried that there's potential for this to happen with dengue in the future. So just in conclusion, there is some evidence that the dengue global burden is progressively rising. This is a common problem in travelers. It looks like clinical manifestation travelers are relatively similar to those in endemic areas. Fortunately, severe dengue is relatively rare, but severe and fatal dengue may occur in travelers, and this may be associated with a primary infection. And I think the biggest worry with climate change and the gradual expansion of the vector, that the potential for introduction and local transmission in the US and Western Europe is going to continue for decades to come. So I'll stop there and turn it over to the next speaker. Thank you.
Wonderful. Thank you, David. Appreciate that. And as a reminder, please put your questions in the Q&A, and we'll get to those at the end after all of the speakers have talked. So I'm going to be turning it over to Stephen Schofield, who will be talking about his topic here, which I'm sure will be full of great jokes.
Thank you, David. Thank you, Christina. It is indeed a pleasure to be here. So I'm coming to you from Dunrobin. I'm just outside of Ottawa. We had 50 centimeters of snow 2 days ago. Today we're getting 20 centimeters of snow. So it indeed is somewhat odd to be talking about dengue today. Nonetheless, I'll do my best. Disclosures. I have been a paid scientific advisor to the Canadian Tire Corporation. That's almost a dream of many Canadians that work for Canadian Tire, specifically to provide advice on their permethrin-treated materials for prevention of mosquito and tick bites. I am also very much wedded to the approaches, the ideas, the recommendations of the Committee to Advise on Tropical Medicine and Travel. So in my day job, I work for the military, and one of the things they like all the time is what they call the bottom line up front, the bluff. I kind of hate the acronym, I kind of like it. But here's the bluff for my presentation. Now, when I was invited, Yen asked that I talk about new things, new innovations related to personal protective measures. And the reality is, strategically, there ain't all that much that is new. It's still topical repellents or skin repellents, treated clothing, etc. Maybe tactically a few things, new active ingredients, but it's the same old, same old. That's okay, because personal protective measures work and they're safe. And I'll elaborate on these points in a few minutes. They don't work, of course, if they're not used. This is their Achilles heel. For example, topical repellents like DEET, like Picardin, like PMD, don't use if you don't put them on. Don't work if you don't put them on. As well, from a performance perspective, they're not optimized if you don't put enough on. And many travelers, for example, or many individuals in their home country context don't put enough repellent on to optimize protection. And of course, they're cosmopolitan. They're just not for dengue. They work against mosquitoes, they work against sandflies, they work against ticks, etc. And this is a good thing. So I very much enjoy talking to our military personnel, Canadian military personnel that is, who are traveling overseas. For example, our United Nations military observers going to DRC, going to South Sudan. And one of the things we try to get across is the context that they're going to experience is different. And their heuristics might be maladaptive, their cognitive rules of thumb, if you will. So I'll ask them, and I ask you, and perhaps you can put this question to your clients. How often do you use repellent at home? And let's talk about skin repellents. How often do you use it inside? For my military personnel, how often do you use it in field exercises in Canada? And I'm going to use myself as an example here. So I'm in Robin. We have about 40 acres, a couple of wetlands. We make a lot of mosquitoes. But we don't have mosquitoes that transmit diseases by and large. They're nuisance mosquitoes. So you asked me the question, how often do I use repellents? Almost never. On my property, never in my house. The rare occasions when I use it are when the biting pressures are unbearable. So my trigger to use is nuisance. It's not concern about disease. If you're to ask me, would I use repellent inside for 5 or 10 mosquitoes? The answer would be never. However, this is exactly the scenario that we might encounter with dengue, with Aedes aegypti, where house populations might only be 5 to 10 mosquitoes. So your approach, your heuristic, if applied in the North American or temperate sort of context, is maladaptive. We're not dealing with nuisance, we're dealing with vectors. You ought to, for example, recommend individuals use repellents by rope. And for aegypti, because it bites inside as well. David did a very nice job of talking about Aedes aegypti, the primary vector of dengue. I'm going to revisit it. As he pointed out, it's peridomestic, typically found in urban, peri-urban environments. Unlike the most efficacious malaria vectors, it is a very recent beast in terms of hitching its horse to the human bandwagon, only a couple of 100 years ago. So why is it such a good vector of the dengue virus? There's a couple of reasons. It feeds inside, it hangs out inside, it feeds on us, and it's pernicious. That is, it can sometimes take multiple meals between the laying of eggs. All of these things combined mean that it has a lot of opportunities to pick up the virus, and after doing that, many opportunities to transmit it. So it's an efficient vector. As I alluded to, it's cold intolerant. Irrespective of climate change, for example, I'm not going to have Aedes aegypti anytime soon in my backyard in Ottawa. And I think this is a crucial difference. And let's compare and contrast with a very efficacious, the most efficient malaria vector called Anopheles gambia sensu strictu. Anopheles gambia, the malaria vector, its raison d'etre, its modality is to bite almost exclusively humans and usually inside. So very similar to Aedes aegypti, humans and inside. But gambia, the malaria vector, bites at night. Aedes aegypti, while it can do that, tends to feed during the day, often in the morning, in the afternoon. Bed nets work extremely well for preventing the bites of gambia. However, relatively speaking, if you have a beast that's biting during the day, you're not under your bed net. So different modalities come to the fore. So the remainder of my outline, I'm going to revisit what David talked about, the likelihood of infection with dengue during travel, because I think that positions us in terms of thinking about harms and benefits. For example, of using countermeasures. We're doing this more these days in CatMat, and I think in general, whether it be for travel medicine, whether it be for COVID or otherwise, we're parsing harms and benefits more carefully. We'll speak about host finding briefly, because the countermeasures I will speak of actually target the behavioral repertoire of the mosquito that culminates in finding and feeding on its host. Talk about preventing bites, and time permitting, and I'll ask Christina to yank me off the stage if I go much beyond 20 minutes. Time permitting, we'll talk about some odds and sods like resistance. So again, positioning harms and benefits. What is the likelihood of infection? Remembering that many infections with dengue don't lead to significant clinical disease. What is the likelihood of infection in a traveler? We undertook a meta-analysis and systematic review of this some years ago. We didn't publish it. Why not? We tend to answer our questions and then move on in terms of our group. But what I want to highlight, and this is consistent with the evidence that David showed earlier, is we're looking at attack rate. So the likelihood that you're recently infected with dengue after return from travel, and then the incidence rate, which is simply an expression of this, but against a time denominator, in this case, per 1,000 person months of exposure. Now I've highlighted something in red and I'll come back to it. This is the only military study included that is a military population. The rest are in civilian populations. In terms of attack rate for infection, it was about 2.4%. It's neither astronomically high, but it's not trivial either. From a harms and benefits perspective, certainly a situation in which we want to manage the threat. I want to come back to the military study. It is interesting in that their incidence rate, so their likelihood of showing recent signs of dengue exposure per unit time, was lower than any other groups. We're not sure why, but there are a couple of possibilities. One, the military does things differently. For example, sometimes we protect our populations by having a base, by putting them in an air-conditioned environment. And two, this is an American military population. They are essentially obligated to wear permethrin-treated attire, which might reduce the risk of infection with dengue. So it is a substantive likelihood of being infected, but not a massive likelihood of being infected. Let's speak to host finding momentarily. Again, because we are targeting this repertoire of behaviors with our countermeasures. So when you think mosquito census, when you think mosquito host finding, think dog, not human. Mosquitoes use their noses. They look different. than the nose of a dog, but nonetheless, they are using smell to find their host. This happens to be Daisy. She's our new golden retriever after an exhausting night of cleaning out the dishes. So how do they find their food? They find their food. They're like little lions looking for the little bit of blood from a distance, not hundreds of meters, meters or tens of meters inside or outside. They're using their noses on their antenna, on their pelts, and they're smelling us. For example, we give off carbon dioxide, aliphatic acids, octanol. So they smell us from a distance, they fly into the air current, eventually approach us, other cues, some odor, heat, visual, then come to the fore, and dictate whether they land, probe, feed, and imbibe blood. In terms of the modalities we're speaking of today, essentially we have two groupings. Those that act very near to us in the green. So the mosquito has to land or be very close to us for them to exert their effects. So topical / skin repellents, barriers like clothing, insecticide treated clothing, bed nets, and for that matter, should something land, mosquito whacking. We also have old / new technology, spatial repellents, mosquito coils, more recently emanators that put insecticide into the air currents can actually exert their effect some distance from the host. I stress these things are not mutually exclusive. It's like a layered mitigation strategy. If you use them all, you further reduce the likelihood of receiving bites. So bite prevention. We've already talked about most of these. Topical repellents, skin repellents, so DEET, Picardin, IR3535, PMD. Spatial repellents, old style, coils, or emanators, new style. Clothing treatments where we put permethrin directly into the fibers of clothing to prevent biting. And insecticide treated materials, for reasons I already identified, perhaps not as efficacious against Aedes aegypti, but there is evidence that treated materials can reduce the burden of Aedes aegypti in a house. And further, of course, sometimes we can have dengue and malaria overlapping, in which case it would be reasonable to use bed nets. So are they safe? The US EPA, Health Canada, the US CDC, the WHO, European authorities say yes, and they use very stringent safety evaluations. So they are safe, or they have an acceptable safety profile, perhaps more appropriately, if they are licensed / registered, and they are used appropriately. Do they work? Oh boy, do they work? And let's answer the question of preventing bites first, or at least look at that. I'm an old dude. This is some work we did some time ago in Winnipeg, Canada. It's like a mosquito capital in Canada. We're not dealing with vectors yet. We're just talking about mosquitoes in general. And so we're using or we're testing 30% DEET in this particular experiment. So we put people out, they put DEET on, they're perfectly behaved, they're not moving around, they're not rubbing the DEET off, etc. And we see no bites for more than 6 hours. Based on intermittent sampling with untreated controls, we would expect more than 5,000 bites to have occurred over the same time period in the absence of repellents. So 5,000 bites to no bites. They work. But of course, the issue is people often don't use them. This is some work we did again some time ago in Afghanistan, a group of 1,000 deployed military personnel. I like it because we asked the question, for example, of these individuals, are you using repellent right now? Our primary concern was a disease concern. Low risk of leishmaniasis, low risk of malaria. You note the second column? About 10% of individuals were using repellent, irrespective of rank, gender, etc. When asked, why weren't you using repellent? A common answer was because we didn't notice any mosquitoes. So they were using their Canadian heuristic of nuisance in a context where we wanted them to use the heuristic of preventing the bites of vectors. And this is a major limitation of, for example, use of topical repellents. Do they work too? The general case previously, now we're going to talk about specifically Aedes aegypti. Some analysis I did a long time ago, 20 years ago for Health Canada, We're looking at complete protection time, so no bites whatsoever in minutes, against a percentage of DEET. For Aedes mosquitoes, half of these trials with Aedes aegypti. And we see profound performance levels for DEET, although we do have an asymptote around 30%. The point being, these things work very well. That is topical repellent, skin repellents, for preventing the bites of Aedes aegypti, full stop. What about effectiveness? What do we see in the real world, in randomized clinical trials, for example, in terms of performance? The answer to that is there is no robust evidence to indicate that in RCTs, topical repellents reduce the rate of infection with dengue. Essentially, it hasn't been evaluated in a robust way. There are some hints, for example, from outbreak situations, but they're based on surveys, so we don't have that evidence. What about treated clothing in Aedes aegypti? Very nice study, essentially in a large laboratory setting, looking at the utility of treated clothing versus untreated clothing. And what we're particularly concerned about is in terms of blood feeding, the orange bars. We have fully covered individuals in terms of treated clothing and partially covered individuals, shorts, t-shirts in the other scenario. And we see very high rates of protection against bites, 90% with fully covered individuals, even 50% with individuals wearing shorts and t-shirts treated with permethrin. So it looks good in the lab. We take it to the field, an RCT, a cluster RCT done in Southeast Asia with school children wearing treated clothing, and they find no effect in terms of recent seroconversions resulting from infection with the dengue virus. Why? A couple of explanations. One, the authors put forward is that there was rapid washout of permethrin. After only a couple of washes, much was lost. Perhaps this attenuated efficacy. Another factor could be, for example, the main area for exposure to the dengue mosquitoes was not in the school environment, perhaps in the home environment. So by and large, we have very robust evidence to indicate that these things work to prevent bites. Much less robust evidence to indicate that, for example, in travelers, they reduce the burden of disease. But here's my logic. Preventing bites should reduce exposure to infection. Reducing exposure should prevent disease. These things should work, but the major limitation, of course, is they're not going to work if they're not used and/or they're not used appropriately. So a question that often comes up is, what skin repellent should I recommend? My response to that is this. Firstly, one that works. I'm partial because they tend to have a better database, because they tend to protect for a longer period of time. I'm partial to DEET, Picardin, and PMD. But I think the bottom line is one that's registered and one that people are willing to use. So for example, if someone says, I'd much prefer to use 10% DEET or 10% Picardin to 30% DEET, my response would be fill your boots. I want something that you're going to use versus something that has the highest level of performance. What about permethrin treated attire? Well, we only have one active ingredient, so it's not choices of active ingredients, but perhaps someone would indicate, I'm not willing to wear long pants when I'm traveling. Well, in that particular situation, wear permethrin treated shorts. They may provide some level of protection, as we've just discussed. The CDC's advice in terms of repellents to prevent the bites of Aedes aegypti, specifically in the context of dengue, indicates DEET, Picardin, IR35, oil of lemon eucalyptus, PMD, and undecanone. Things that are registered and things that meet their safety criteria. If I had to pick an argument with the advice, it would be this: use EPA registered insect repellents when outdoors. Absolutely use repellents when outside, but remember Aedes aegypti often bites inside. This is a situation where one might consider, indeed one probably should, use topical repellents when inside. So a few odds and sods. What about resistance? That's a great question. We know that Aedes aegypti, for example, certain populations have some resistance to pyrethroids, the KDR mutation. However, that doesn't change recommendations. The presence of resistance doesn't mean we would not recommend the use of permethrin-treated clothing, for example. Furthermore, we don't even know if this resistance impacts in a meaningful way the protective level that one achieves through use of permethrin-treated attire, for example. Much more data on resistance is available for anophelines, the vector of malaria. Excellent review published this year in Lancet by Stephen Lindsay. He's a very clear thinker. And in essence, he says there's a narrative out there that the slowing of the reduction in the malaria burden around the world is because of resistance and poor efficacy of insecticide-treated nets. He takes this narrative to task and makes the point that we actually don't know this. There are more parsimonious explanations. My point being, we actually don't know for sure what resistance is doing operationally. Super interesting, this. Does infection affect the performance of repellents against, for example, Aedes aegypti, against, for example, anopheline vectors? There's tantalizing evidence to suggest that it can. However, recent systematic review suggests that at least for dengue and for malaria, infected mosquitoes do not seem to have altered behavior. Taking a step back, what I can say, however, is that we do see variation amongst populations of mosquitoes in terms of their sensitivities to, for example, DEET. Anopheles albuminus, for example, a vector of malaria in the Americas, is more resilient to DEET than our other vectors, which means you need to apply it more often. So there is variation in the performance of skin repellents against different groupings of mosquitoes. And so while there's nothing new in the zoo when it comes to personal protective measures, there is some exciting stuff out there in terms of management of dengue at a strategic level. Published this year in the New England Journal of Medicine, a cluster randomized trial from Southeast Asia that were using mosquitoes that were modified. The modified mosquitoes have a parasite, not a parasite, I should say an intracellular obligate bacteria in them called Wolbachia. And what it does is it makes those mosquitoes resistant to the dissemination of dengue virus when they're infected, which means in turn, they're less likely to transmit it. Further, it's a driver in terms of if mosquitoes have Wolbachia and they breed, only the Wolbachia infected progeny survive to reproduce. So you can drive this modification through the population. So in this study, what I'm showing is over a period of time, on the right-hand side top figure, the prevalence of Wolbachia infection, that is dengue resilience or resistance in the mosquito populations, Aedes aegypti, in those areas where they were released. And we see that it reaches almost 100%. Below, where they were not released, and we see that the Wolbachia infections actually start to penetrate into those areas as well, which is very interesting. But the most important point is the bottom figure. What was the protective efficacy against dengue infection? It approached 80%, which for residents of a endemic area is absolutely profound. This could be potentially, time will tell, a game changer. However, of course, a caution. From a travel perspective, 80% efficacy would not change any recommendations we make for personal protective measures. So very exciting, a space to watch, certainly could change things for residents of endemic areas, but doesn't change our current advice. And again, I'm back home to Dunrobin. These are my two boys some years ago playing on our front pond in the winter, where given the temperature, there clearly are no Aedes aegypti. Thank you, and I'll leave off here.
Thank you, Steve. That was wonderful. All right, we're going to transition to our third and final speaker. We're going to turn it over to Dr. Yashim Tozan. Go ahead and take it away, Yashim.
Thank you very much. Let me share my screen. Stephen, I need you to stop sharing so that I can go ahead. Perfect, thank you. And there goes my slides. Okay, so my talk today is going to focus on the impact and costs of dengue illness in international travelers. I'm going to start with some background slides on global travel and how we assess the economic burden of disease, and specifically in dengue. And then I'll build upon basically what David and Stephen presented on dengue and dengue-related illness. Let me also turn my pointer on here, so just in case it's, I would like to point out a few things. So first, some stats on global travel. In 2019, almost 1.5 billion international journeys were undertaken. These stats are from the UN World Tourism Organization agency, and you can see the drastic impact of COVID here. But before that, the same agency estimated that the number would rise to almost 1.8 billion by 2030. So global travel on this scale exposes many people to a range of health risks, different disease agents, and changes in temperature, altitude, and humidity. These are just some of the risks, all of which can lead to basically ill health. And among the regions, Asia and the Pacific region, where arboviral infections are endemic, is highlighted as the fastest growing tourism region in the world. In 2019, as you can see here, this region received 25% of all international travelers. So just going on to the next slide, where we also see a steady rise in international arrivals in least developed countries. This is just a highlight where some of the diseases that you all have been working on much more endemic in greater numbers. Moving on to purpose of trip, basically, where this chart presents in detail an overview, including the time trends and also the share of different reasons. You can see that the travel for leisure, recreation, and holidays accounted for over half of the international tourist arrivals in 2018, and some 12% of international arrivals reported, international tourists reported for traveling for business and professional purposes. And another 27% traveled for specific purposes, such as visiting friends and relatives, religious reasons, or pilgrimages and health treatment. And then there's some trips that we do not have data, but you can see the continuing trend in tourism over here, while the share is kind of relatively stable, but just with a slight increase. In terms of mode of travel, which is kind of important in terms of introduction of these diseases into different parts of the world, you can see that in 2018, well over half of travelers arrived at their destination by air transport, while the remainder traveled by surface, whether by road at 37%, water at 4%, and rail at 2%. You can see here the share for airport arrivals is steadily increasing, and this trend is expected to continue into the future. And overall, we see in the beginning of the 21st century, a marked significant growth in long-haul travel by air, with potential implications for the introduction of dengue and other arboviral diseases into non-endemic areas due to climate change and variability, associated alterations basically in the geographic distribution of vectors. And this was exemplified by the 2012 dengue outbreak, for instance, in Madeira, Portugal, and the 2017 chikungunya outbreak in France and Italy. For the chikungunya outbreak, we assessed as a team the risk of virus importation, virus transmission, and short rate dispersion from the outbreak foci using air passenger volume from international areas with active chikungunya transmission and vectorial capacity estimates of Aedes albopictus mosquitoes. As you all know, these mosquitoes are pretty much established in south of Europe. So next, that I would like to just note the travel-related risk factors. International travel can pose various risks to health, but this depends on the characteristics of the travelers and the type of travel. The key factors in determining the risks to which a traveler might be exposed include mode of transport, destination, duration and season of travel, purpose of travel, and behavior and underlying health of the travelers. Now, keeping these in mind, I'd like to, I think David alluded to this study by Karen Leder and colleagues, the top 10 diagnoses among international travelers by main reason for travel across geocontinental sites. And you can see that dengue over here has its own share, which kind of leads us now, switching gears a little bit, how to basically assess the economic burden of any disease, but including dengue. And I'd like to switch gears and talk about or introduce a framework that we use to estimate the economic burden of dengue, which is applicable to any other disease. The framework includes 4 very different domains of cost items, and it's differentiated also by 3 different potential stakeholders. And over here, the stakeholders are the individuals and households, health providers, and community. So we can look at these costs from these 3 different perspectives. And the 4 domains include cost of illness, and the cost bearers would be individual households, health providers, and community. Community can be an administrative unit like a state at the subnational level or a country. And the second domain includes the cost of routine prevention and control activities. And individuals and households may participate and bear costs. And mostly these costs are borne by health providers in endemic areas. Costs of surveillance and reporting that would usually accrue to health providers. And cost of outbreaks and outbreak management to individuals and households during outbreaks, and health providers and communities, basically due to related activities. So usually we assess the costs in these 4 domains, and to be able to estimate the true economic burden of any disease, including dengue, and compiling cost data that are heterogeneous in nature is basically the key and the major challenge in economic studies. Also these domains give the backbone to kind of an exciting and challenging research programs trying to look into the economic burden of disease. So in the rest of this talk, I'm going to present a prospective costing study that focuses on the first domain and examines the impact of impact and out-of-pocket costs of dengue illness among international travelers. So I'm going to say a little bit more what type of costs that we focus on basically in this domain. Depending on health-seeking behavior and healthcare system, a dengue patient will incur 3 different cost categories due to dengue illness. So here, these are listed, the medical costs that include co-payment, deductibles or full payment for medical services, diagnostic tests and drugs, and payment for services at pharmacies. Again, depending on the context of healthcare, patients may also incur costs related to traditional medicine. And then we've got a large last component that usually gets described as non-medical costs. And these costs include transportation, food, lodging, and other costs related to seeking or obtaining medical care, and also visiting patients at the hospital. So these, from the caregiver perspective, and travel times, days of school or work lost. So it includes, this may accrue to the patients and also the basically caregivers who are taking care of the patients. And this could, these costs may be incurred in the immediate during the acute illness stage, or they might be related to the long-term recovery of the patient and the consequences of an infection. So dengue symptomatic cases appear in endemic communities and also international travelers. And all these costs over here, as you can imagine, vary by age group, pediatric or adult patients, by disease severity, whether the disease is complicated or the case has complications, experiencing complications, which might be dengue hemorrhagic fever in the case of dengue, where the patient sought treatment, whether totally treated at outpatient facilities or with severity inpatient or a combination of both, and the type, the provider type where these medical care is sought at public or private facilities. So that pretty much gives us the methodological framework to look into the costs of dengue illness in international travelers. And our main motivation for conducting this study was that the impact and costs of dengue illness from this particular perspective have been extensively studied in dengue endemic population because of limited financial protection of these populations. But similar studies have never been conducted in international travelers. Here, I give references to a few studies that we conducted on cost of illness in endemic communities, one in Sri Lanka, one in Thailand. Basically, what we did in this study is that we used the same patient survey, and we adapted, given that our target population is this time international travelers. So just to wrap up in terms of motivation, why we looked at dengue costs in international travelers, as you have heard from Stephen and David, the past few decades has seen basically an unprecedented growth in global dengue burden, and international travel is also increasing, and so is illness in international travelers. So the exposure is at a higher level. And this was also picked up by the studies from these large surveillance networks, where the dengue has become the leading cause of febrile illness among ill travelers, particularly returning from Southeast Asia and Latin America and the Caribbean region. And dengue illness can pose a considerable financial burden on international travelers due to those, particularly two categories of costs, medical and non-medical costs. And within non-medical costs, we basically can talk about income and other financial losses. So just diving a little bit into to the details of this study, we conducted a prospective costing study in 8 major travel tropical medicine clinics. These clinics were located in Australia, Austria, Germany, Israel, Italy, the Netherlands, Switzerland, and the United States. We got hit by a couple of epidemics at the time that affected our recruitment activities, but in the end, we managed to recruit 90 adult travelers with laboratory confirmed dengue diagnosis. The mean age was 31 and with a range of 18 to 74. As I said, we adopted a patient questionnaire that we used in endemic communities to elicit information on patient demographic and socioeconomic characteristics, patient's travel history and purpose, pre-travel health consultation, dengue episode characteristics, patient's treatment-seeking behavior, both at destination and home country, healthcare utilization and associated out-of-pocket expenditures at the point of service, again, at destination and home country, income and other financial losses of patients and accompanying persons due to this specific illness episode, and also impact of dengue illness episodes on work and school life, which is really limited information even in endemic countries. So our analytical framework basically included, our unit of analysis was the laboratory confirmed dengue case and the cost components that we measured at destination and home country included the direct costs by treatment setting and geographic location, which included the medical costs and non-medical costs. And we grouped the indirect costs for this target population as income loss due to illness, non-refundable prepaid travel costs, and travel costs of accompanying persons during illness. All cost information was based on self-report to be able to control for bias. We basically recruited patients who returned ill within the past 8 weeks, and reimbursements paid to households by health and or income protection insurance subtracted to arrive at a total cost per case. And the total cost per dengue illness episode was estimated by summing the direct costs and indirect costs. So that's the methodological background. And now on to some results. So here you can see that from the data, most travelers were prepared. Most patients reported visiting countries in Asia, followed by Latin America. Almost 3/4 of patients, 74%, self-reported to be traveling for tourism, and they were mainly high-budget travelers. And the median duration of travel was 18 days. And this ranged from 3 days for business trips to 255 days in case of visiting family and friends. I think I covered all the stats on this slide, and on the next one, most travelers received travel advice before traveling. And the majority of travelers reported using personal protection measures during travel. And when we assessed the costs, these costs average about $23. Only 3 patients were previously diagnosed with dengue, and none experienced severe complications. And you can see that the duration of fever was about 6.2 days, and patients felt most sick about 2.5 days on average. All right, so on to their health-seeking behavior. What is very clear here is that patients really utilized healthcare services at home more frequently than at destination country. So at the destination country, only 22% were hospitalized, with a mean hospitalization duration of 3.7 days, and none required intensive care. At the home country, 39% of patients were hospitalized and spent a mean duration of 3.1 days in the hospital, and only 1 patient received intensive care. And you can see that the number of ambulatory care visits also is higher, in this case, higher in destination country before they arrive at the home country. What we see in terms of direct costs, which includes the medical and non-medical costs, out-of-pocket total spending for both hospitalization and ambulatory care at the destination country was much higher. And at the home country, out-of-pocket medical spending was negligible for hospitalization, which may point out more cost sharing protection at the home country, but it wasn't non-trivial for ambulatory care. And next is that I'd like to present just the overall results. Here in this figure, you can see the average costs, average total cost for patients who sought only ambulatory care during illness episode, which is averaging to $253. And when patients only sought hospitalization, the average total cost was $254 per case. And then you can see that when patients sought both ambulatory care and hospitalization for dengue illness episodes, the cost went up to $992 per case. So the costs were similar for patients basically seeking only ambulatory care or hospitalization. And you can see that we provided a little bit more information into the nature of costs, total costs, and you can see that the distribution spikes at 0, reflecting patients with no costs. And you can see that some patients, most of the patients also reported that they have some sort of health insurance coverage to cover themselves for costs at home and overseas. And at the point of service utilization, these insurances basically worked and they didn't need to make any out-of-pocket expenses. And you can see the number of patients over here and the total spread of costs over here across the 90 patients. All right. Here I would like to present also how the costs varied by home country, reflecting basically the nature of healthcare systems. This is in basically increasing order of health out-of-pocket expenditure per capita spending in each country. Netherlands had the lowest per capita expenditure, whereas Switzerland has the highest. Our low sample size and variety of destination countries basically precluded us from making robust comparisons across country settings, but nevertheless, the data is pretty much novel despite the limitation in the sample size, and showed a couple of important points where larger proportions of travelers were hospitalized or received ambulatory care at home country. Given that there was not much, actually not severe complications, almost, all patients, it is unclear whether these hospitalizations at home country was necessary or appropriate. You can see that the average total out-of-pocket costs that we estimated was $992 per case, which was non-trivial. And I already pointed out the major limitation is the small sample size, but we are trying to get around this by collecting data from a larger group of travelers, as David mentioned, and one longitudinal study, Chizidema. And so please stay tuned for results from that study to have an understanding how numbers are changed. So I'd like to end by some concluding remarks. Dengue disease cases among travelers have been increasing as the overall burden of dengue expands globally. So this area is important to conduct future studies, also from an economic point of view. Costing studies from the perspective of patients provide us with an understanding of welfare loss associated with illness and the potential financial benefits of disease prevention. So it's important for prioritization of different interventions targeting this group in particular. Although costing studies fail to measure and value this utility, for instance, we didn't try to quantify, the cost of pain and suffering. These intangible costs are very difficult to measure, but these costs are pivotal in assessing patients' willingness to pay to avoid another similar episode, and can be compared against basically the cost of preventive measures, such as vaccines targeted at this population, and can help with their prioritization in this population. And out-of-pocket costs incurred by patients provide us with only a partial estimate of the societal level economic burden of travel-acquired infectious diseases. In this paper, we kind of provided a ballpark estimate of dengue illness episodes to healthcare providers, and these costs range from $3,000 in Italy to over $8,000 in the United States. As you can imagine, these healthcare provider costs change by country and healthcare setting and type of healthcare provider. If you would like to read a lot more about this study, it's been published in the American Journal of Tropical Medicine and Hygiene, and it is the first study to investigate the impact and costs of traveler-acquired dengue illness in travelers. And I'd like to give a shout out to all my collaborators over here listed for their hard work in the context of this study. So I'll stop here and open up the platform for any questions.
Thank you, Yashim. That was wonderful. So we're going to transition quite quickly to our Q&A session. We have about 7 minutes left. We have a series of questions just for everyone's awareness that the panelists have already answered, and they'll be in the answered tab in the Q&A. So we have a few open questions, and I'm going to direct the first one to Dr. Hamer. Is there any way to quantify the risk of severe dengue in travelers with a history of disease as they go to high-risk areas?
So I think it's useful trying to get a history of dengue fever, and if it was laboratory confirmed. There may be a role for checking serologies. Certainly if in places where Dengvaxia is licensed and is able to be used, recommendation is to check a serology and make sure somebody's antibody positive before getting the vaccine, because seronegative individuals may have a risk of basically responding well to the vaccine initially and then having a greater risk of severe disease with time. I'm not sure whether there's a direct relationship between, say, a quantitative IgG and subsequent risk of severe dengue in travelers. I can't answer that question, but I think it's definitely worth screening with at least a question and potentially a test. And especially if somebody has a fairly certain diagnosis, just to confirm it.
And related to that, Dr. Hamer, would you use that testing in the decision whether to recommend vaccine to someone?
Yes, I mean, if it's Dengvaxia, yes, because the recommendation is to test, and then if the test is positive, to use it. The Takeda vaccine is not out yet. Probably will not have that requirement, but we'll see when that comes out and undergoes review.
Great, thanks. And the next question is for you, Dr. Schofield. What are the most common reasons for a delay in diagnosis and misdiagnosis?
Well, I don't think Dr. Schofield is best placed to answer this one. I think Dr. Hamer is.
Yeah. Well, you clicked on.
You said you would answer it. That's why I'm directing it to you.
I lied.
I'm happy to take a shot at it. And I think there's a couple of things. One is if people don't take a travel history and there's travel associated dengue, then you're going to miss it. And that goes for malaria and many other diseases. I think that if a general practitioner or family medicine provider, somebody who's not a specialist, is not aware of dengue, is not thinking about it, then they're not going to test for it or not think about it. And I think that's exactly what happened in the case that I presented in Miami, that the providers there just weren't thinking about dengue. Of course, that was a little bit different because it was probable local transmission. But certainly starting with a travel history and then thinking about dengue is really important. There could also be a delay on the part of the traveler. They may just say, I've got a febrile syndrome, I'm just a little achy, I've got a flu-like syndrome, and delay presentation. And then in terms of misdiagnosis, well, I think that there's a lot of overlap with the symptoms of dengue with, say, COVID-19, and so. These days, I guess that's sort of the title of the seminar in a way, sort of dengue in the time of COVID. I think that if somebody came in with, a fever and some of the other symptoms and didn't have a rash, then COVID would be top of the list. And that could lead to a misdiagnosis. And the other thing is if, say, there's a chikungunya outbreak somewhere and people are really focused on chikungunya, there's a lot of overlap in symptoms. So as I mentioned, I think if you have areas, many times all three viruses may circulate in an area of the world. I think it's important to think about all three and test for all three to avoid a misdiagnosis.
Great.
Thanks, everybody. And thanks, Christina, for moderating this excellent session. Thanks to all our speakers. And I just want to remind you that we have our upcoming travel medicine update and review course that will take place online on February 11th and 12th. And for those who wish to sit for the CTA's exam, that one will also take place online on March 29th, 30, and 31st. So I'm looking forward to those events and talk to you again very soon. Take care and have a good 2022. Thank you. Bye-bye.